All right. Hi, everyone. Welcome. My name is Eliza Mejia. I'm Meetup's Senior People Partner. Thank you so much for joining us today for our Ending Disparities in Mental Health Care discussion with Dr. Karinn Glover and Ymani Hawkins. This is our fourth installment in our Dismantling Social Injustice series. You may have joined us in previous events where we've discussed voting rights, urban policy, and allyship. If so, welcome back. And if this is your first time joining us, a huge welcome. Our goal is to continue fostering important conversations through events like these. All right, I'm gonna go over quickly the guidelines for our event today. Just so you know, our event will be recorded. It will be available for viewing on our blog after this session. You will be muted for the remainder of the session, and the chat feature has been disabled, but if you have questions or comments, please enter them in the Q&A function. All right, I'm gonna go ahead and introduce our two amazing panelists today. First, we have Dr. Karinn Glover. She is the consulting psychiatrist in the primary care division of the Montefiore Health System. Dr. Glover is also an assistant professor of psychiatry at the Albert Einstein College of Medicine. She teaches psychopharmacology and aspects of psychotherapy to internal medicine and family medicine residents. As a consulting psychiatrist, she is a member of a system-wide collaborative care-based program to provide direct psychiatric care to medically and psychosocially complex patients in the Bronx. Dr. Glover has authored a peer-reviewed article on mental health disorders in primary care, contributed to a textbook on psychiatric treatment in primary care, and has extensive experience in psychopharmacology and substance disorder treatment, and contributed to various media outlets on a range of topics related to mental health and wellness. Dr. Glover graduated from Howard University with a BA in history. She followed her curiosity about medicine and ultimately attended SUNY Downstate College of Medicine and obtained her Master of Public Health from Columbia University's Mailman School of Public Health via the highly competitive Macy Scholars Program. Welcome, Dr. Karinn Glover. We also have the amazing Ymani Hawkins with us today. She is a psychotherapist and a diversity wellness coach. She is the founder of Deepish, a soon-to-be-launched consulting firm bridging the gap between mental health and diversity, equity, and inclusion. In her work, Ymani focuses on racial trauma, promoting self-care and mindfulness strategies to address topics amongst microaggressions, racial battle fatigue, and emotional labor in the workplace. Previously, she delivered inpatient and outpatient treatment services to clients of all ages and backgrounds, experiencing severe and persistent mental illness such as dissociative, depressive, anxiety, and psychotic disorders. Ymani holds a Master of Social Work from the Silver School of Social Work at NYU, a BA in Interpersonal Communication Studies from King University, and she's performed ethnographic research in Siargao, Philippines, and studied business and marketing in Athens, Greece. Ymani seeks to share her expertise and utilize her unique perspective of the world to drive sustainable change in the DEI space and build long-lasting professional relationships. So I want to welcome you both. We're so excited to have you in our discussion today. And I'm going to hand it over to Ymani to start us off with a bit of a mindfulness practice.
Absolutely. Thank you so much for having me. Before we begin, I think it's really important that we all bring our full selves to this conversation. We'll be discussing topics related to mental health, wellness, and care. So I think it's most appropriate that we begin with checking in with our own mental state. I want us all to participate in a mindfulness exercise called STOP. It's an acronym that tells us to stand, tune in, observe, and explore possibility. When you are comfortable, I would like you to stand, or you can sit with your back posture straight up, and we are going to begin. So the first part of this exercise requires you to soften your gaze if you feel comfortable, or close your eyes. I want you to begin to breathe deeply in through your nose, filling your belly up with air, and then releasing that air out of your mouth. Complete this step about 3 times. I want you to transfer all of your weight to the bottom of your feet. Imagine that you are anchored to the floor, and the upper part of your body should feel light and free. I want you to continue to breathe, gently redirecting your attention back to your breath when your thoughts begin to wander. Our next step is to tune in. Here, I want you to scan your body, from your head to your toes. How are you feeling? Relax your shoulders, unclench your jaw. Drop your tongue from the top of your mouth to the bottom of your mouth. Loosen your thighs, your glutes. Wiggle your fingers, wiggle your toes. Check in with yourself. Do you need water? Do you need to stretch? Take a moment to tend to those needs. Our next step is to observe. If your eyes are closed, you can open your eyes if you feel comfortable. And I want you to focus your attention on something in your environment that is pleasant. Observe its beauty and be grateful for it. Eliza, I see a plant behind you. I'm looking at that. And our last step is exploring possibility. What do you want to take away from this conversation? Please note that today's discussion may evoke feelings of anxiety, sadness, anger, guilt, frustration, or even helplessness. We're talking about a lot of heavy things. Acknowledge those things as they are markers, signifying and representing how aware we are of these issues related to unconscious bias, racial and ethnic disparity, allyship, and mental wellness. Remind yourself that this is an opportunity to learn and to listen. Give yourself the space to explore infinite possibility and the grace to learn together. When you are ready, you can sit down if you are standing and focus your attention back to the screen. And as we dive into the topic of mental health and wellness today, I really want us to honor and hold space for those who may be feeling the weight of the news regarding Breonna Taylor. We invite you to honor your emotions, as you may feel a lot of them during these times, and take the necessary time and space needed to address those feelings. Thank you.
Thank you so much, Ymani. That was wonderful and a great way to start off our discussion. So I'd love to kick us off and ask you both kind of an intro question. In terms of mental health care, where are we? What are some of the mental health care disparities, and who are the people who are mostly affected?
So I think I'll start by just saying that, first of all, thank you for inviting me to be here. And one of the things that I want everybody to know is that mental disorders are pretty common in everybody's population. Everybody. You could be a Muppet. You have just as much likelihood as having depression as somebody of a different ethnicity, okay? So it's just a matter of how the illness or how the condition plays out over time. And what do I mean by that? An equal number of us are depressed, anxious, have schizophrenia, bipolar disorder. The difference is, how easy is it to get connected to care once the problem arises? And unfortunately, in the Black and Latinx communities, there are lots of reasons why it's harder to get care. That also goes for Indigenous communities as well. And that's a combination of stigma. It's also a combination of lack of insurance. And it's also a result of historical interactions with medical systems, interactions that have been unfavorable, unkind, traumatic. And then on top of that, it's also how easy is it to find somebody who understands the culture of the person seeking help. And that has a large effect on how the person remains in treatment, how they engage in treatment, and even sometimes treatment results.
Thank you. I'm just going to echo a couple of things that you said. I think it's important to understand the distinction between what mental health care is defined to be versus what it is in actuality. These services are supposed to be about providing essential health care that is accessible to individuals and families within the community. But as we talk a little bit, you'll come to understand that disparities that disenfranchised populations face in terms of access to and adequate supply for mental health care is a little different. It's important to note how intersectionality, like Karinn said, plays a key and complex role in all of this. And some of those intersectionalities are race, class, socioeconomic status, gender, and how these play a vital role in mental health care. And we can't really have a conversation without acknowledging those things. 53% of adults in the United States have been negatively impacted by COVID in general, right? But this worry and stress is compounded for folks in the LGBTQ plus community, for Black and Indigenous people of color, due to poverty, healthcare discrimination, denial of care altogether, and stigma, which are some of the things we're going to be talking about today.
Definitely. So how would we go about connecting those people to treatment? Who are the gatekeepers for this?
Ymani, you got that one? Or you let me know when you want me to hop in?
I think a gatekeeper person is a person who regularly comes into contact with people who experience mental illness. And like Karinn said, this can be any one of us. I know I struggle with anxiety, right? And so this can look like mental health care providers, or can be fulfilled by people like probation officers, clergy members, cab drivers, teachers. This can also be people in the community, right? Family members. However, I want to note that this is a role that, you need education for, right? And so the role consists of learning to recognize the signs associated with mental illness and suicide, identifying risk factors, navigating conversations around mental illness, and making referrals and providing adequate and appropriate care to those who are in need. And I know a training, it's called QPR training, or Question, Persuade, and Refer training. It's about a 1 to 2 hour educational program designed to instill fundamental principles about mental health and how to unpack warning signs and, utilize interventions when it comes to someone with a mental health need.
Can I also add that one major force that I think doesn't get talked about enough is this sense that, well, if I feel this bad, what happens if I show up for treatment? What kinds of records are going to be maintained about these innermost parts of my life, and who will they be shared with? So that's one concern. And then, of course, there's this major concern, like if a loved one is very, very upset and I need to call EMS, does that mean the police will come? We know that in cities where the cops are not trained in how to manage interactions with folks dealing with mental health conditions, that there can be some really violent outcomes, sometimes death. Some of those interactions are fatal. And so there is a hesitation to interact with the gatekeepers. So I think we should just keep that in mind, that sometimes there can be fatal consequences. And different cities are doing different amazing things to make it easier for people who are trained to be the gatekeepers, just like Ymani said.
Definitely, thank you. So I'd like to dive into a little bit of a history, or how we got here. How has unconscious bias played a role in the disparity of mental health care for different populations, and how does it perpetuate some of these challenges even today?
So I think a major thing to keep in mind is that in lots of cases, science reflects the biases of the time. So in 1850, for example, people were still enslaved. My ancestors were enslaved in the United States, right? And so the science reflected the time. The time was all about Black people are not fully human, and neither are the Indigenous people. And they don't have names, they don't have culture, they don't have a history, they are a chattel, they are property. So when people who were enslaved tried to escape, psychiatry, reflecting the time, said, well, there must be something wrong with them. Why would they want to leave our care? So they developed a diagnosis called Drapedomania to describe Black people who sought their freedom. We now know that it is entirely within the realm of normal mental health to want to be a free, fully human person, right? And so it's amazing the way that the science has changed, right? So it's not like medicine has gotten rid of all of their unconscious biases. Right, we know that the builders of medicine and the gatekeepers for medicine were traditionally white men. So medicine reflects often the biases of the folks who are the gatekeepers. And I think in this time, the way that it's reflected is that often Black and Latinx pain is either misconstrued or often misdiagnosed. For example, in our society, even as recently as a study in 2012, people who are skilled clinicians interviewed Black people who had symptoms of psychosis and mood issues, and they interviewed white people with symptoms of psychosis and mood issues. Routinely, the white people's pain, their emotional ups and downs were taken into account in formulating the diagnosis. So somehow the clinicians could say, this person has depression with psychotic features or schizoaffective disorder. Any disorder that takes into account this person's emotional ups and downs. For whatever reason, unconscious bias, the Black and Latinx, particularly the Black participants in this study, were routinely only diagnosed as being schizophrenic people, as people living with schizophrenia. What's the downside of that is that their pain, their emotional ups and downs were not taken into account. And when the researchers went back and asked the clinicians, you seem to have missed that this person talked quite a bit about their depression symptoms, their highs and lows. And the clinicians said, well, I just thought that the Black people were being dishonest. So really, I think this is a wonderful, very impactful time of reckoning in every field, everywhere in the United States and around the world, because we know that even though people who have the best intentions of treating people like they're fully human and taking into the broad spectrum of their emotions, subconsciously, it sometimes does not happen, and it skews along cultural and racial lines.
Right, and just to add on to that, I was reading something recently, just for my own personal knowledge, why isn't racism diagnosable, right? And at some point, Black psychiatrists were trying to make this come to fruition, but it just ended up being that it was too common to be diagnosable. And that's the unfortunate reality of what we're dealing with, right? But to add on to that, in academic settings, we can see students who actually need the most support, like students of color, students who are differently abled, children who experience trauma, and LGBTQ youth are disproportionately impacted by school discipline practices. And something to consider when we talk about unconscious bias is the school to prison pipeline. And sometimes we don't associate the two together, but it's this notion that breaks down the correlation between school and the criminal justice system. And time again, we see, the manifestations of unconscious bias exacerbated in the classroom. And when Black and Indigenous children of color get in trouble at school, it can lead to their first infraction, with the justice system, criminal justice system. Approximately 92,000 students were arrested in school just in the 2011-2012 school year, according to the U.S. Department of Education statistics. Unconscious bias is a little tricky because we all have it, and it's a matter of fielding through what is appropriate, what's not appropriate. It's appropriate when I want to select chocolate ice cream over vanilla ice cream, right? But it's not appropriate in other contexts. And when you're talking about academia, you know, teachers, staff, administrators, and school police officers may see their disciplinary actions as justified or even necessary. And this is really unfortunate. And the need for cultural awareness and sensitivity is essential when we talk about mental health. Unconscious bias and lack of understanding around culture perpetuates misinterpretation of emotional expressions. And I know, Karinn, we talked about, you mentioned before this conversation that, you know, a Black man listening to rap music may be his, you know, choice in avenue for outletting his emotions and expressing those emotions, but to us, it's like violent, right? And to that point, another example is the disproportionate rate of African-American children who are diagnosed with oppositional defiant disorder. And this is a disorder that encompasses anger, defiance, argumentative behavior, and vindictiveness, right? Rightfully so, you know, being a person of color. However, white American clients presenting the same exact, you know, disruptive behavioral symptoms are instead diagnosed with adjustment disorder. So unconscious bias leads providers to believe that Black and brown clients exemplify deficit, oppositional, and conduct disorder issues. And the lack of cultural awareness is really kind of hurting us, you know, literally and figuratively. And so we are then left to not use the resources that we're supposed to use in terms of, you know, psychiatric and medical help. And we kind of, you know, revert back to our family and our community and our spiritual support system.
Could I also add to what Ymani said, two things that I found out about recently. One is that this came from Sarah Vinson, who's a child and adolescent psychiatrist based in Atlanta, and she works on the Judges and Psychiatrist Leadership Initiative, the JPLI. And they found, and this totally relates to what Ymani just said, that during COVID, schools traditionally rely on the carceral system, right? Like the justice system, except I refuse to call it the justice system because there's so much that's unjust about it. And they rely on that system to get and maintain kids engaged in school, right? And instead of sort of engaging with social work sometimes and finding out what's going on in the home that's preventing this kid from being fully engaged and finishing their homework, et cetera. During COVID, right, the kids were not at school. So there was less of an interaction between the police and these kids when it came to attendance and finishing homework and stuff like that. So it's interesting because there's this difference lately around the levels of interactions with our kids and the carceral system during COVID because they had to engage differently with the school setting. And I think that that's something to pay attention to, like as school ramps up, as kids who maybe have been living at home and, you know, sequestered at home or quarantined at home and maybe didn't have the safest homes or the safest neighborhoods or the safest places to access Wi-Fi, as they're expected to show up for school, they may be behind. How are they tolerating that feeling of being behind? How are they going to express themselves? And then if they express themselves in a way that reflects trauma, will that be misdiagnosed as ODD? And if you get misdiagnosed as ODD, that goes into your chart, that goes into your school records. And how does that, excuse my language, how does that F you up for the future, right? How does that just get in the way of your progress and you actually getting your needs met? So.
I think that's actually a really great segue into a little bit of how economics play a role in these disparities. So folks are impacted due to housing, limited resources, inability to get medication, and a slew of other things. Can you talk a little bit more about barriers preventing disenfranchised populations from receiving adequate health care?
So, barriers to care. So, for lots of people, like we mentioned before, there's stigma, right? Like this belief that if you have any kind of need to talk to a professional, that must mean you're crazy, right? Like there's this, instead of seeing things as a spectrum, it's seen as a very on or off, black or white issue, when it's not. There's a whole spectrum, a whole array of ways that people can manifest mental health conditions and ways to receive treatment. So that's one thing. But instead, our society tends to say either you're this or that, but nothing in between. So, and then on top of that, there's layers of stigma, because historically mental illness and mental health conditions are portrayed as only severe and unremitting and a sign of weakness, right? And so part of a lot of people's spiritual beliefs are often that to need mental health help is a sign of a lack of faith or a sign of spiritual weakness, right? So that's something that exists within lots of cultures, African American culture, West African cultures, almost worldwide, I would say. Lots of Asian Americans have come to me talking about that as well, and that's well documented in the literature. Additionally, right, there's these barriers of like who has insurance and who doesn't have insurance, and how easy is it to connect. And then does the insurance company, can you call your insurance company and say, hi, my name is Karinn, I'm African American, I'd love to see a clinician who knows my experience, who has lived the experience of being in the minority in this country. And my insurance company would say, we don't keep that kind of data, right? In some ways to protect clinicians of color, to say like, we don't want somebody to call us up and say, tell me about all the Black psychiatrists. I want to make sure I don't go to any of them, right? The hard part is that the downstream effect is that the very people who need the help the most, perhaps, and who are taking the biggest chance in seeking help, are discouraged from that very conversation, right? So the idea is that there's this push now to get insurance companies to keep data on, especially for if a clinician is willing to say, hey, tell everybody I'm African American. My name's Ymani, I'm a therapist. Tell anybody you want who I am and what I do, and let them find me. And whoever doesn't want to see me, will probably be okay. That's one thing. I'll let Ymani take it from here.
No, you pretty much covered it. I was actually thinking today regarding mental health stigma. Black and brown folks are kind of expected, societally, familially, culturally, religiously, to just keep on going. And even today, right? And I was like, we just heard the news about Breonna Taylor. I'm like, I have to do this speech today, keep it together, right? And that's just kind of this thing that we constantly have to do, and wears and tears on our, our psyches, and it's just not healthy. And I think we really need to think about how stigma really plays out in regarding these issues. And it happens when, stereotypes, labeling, microaggressions all come together. And this kind of results in disapproval, feelings of rejection, feelings of exclusion. And then on top of that, you have societal stigma, and structural stigma. And that includes inadequate availability of employment opportunities, or lack of effective health services or transportation, or access to supportive, housing options. And some examples of stigma are the perception, that those with a mental illness are dangerous, unpredictable, or violent, or that they are fully responsible for their own difficulties, which I can say is one of the misconceptions within the African American community, right? Pull yourself up by your bootstraps. Just a quick little thing. I watch A Million Little Things on, I think it's ABC, I'm not sure, but it's a great show. And one of the Black men on the show expresses his attempt to die by suicide, and talks to his father about this, asking his dad, like, have you ever, experienced depression? And his dad's like, yeah, but, I get over it, I move on. And this is kind of the mentality that some people have. There are other misconceptions that they are, people with mental illnesses are not in control of making their own decisions. So they're babied, or they need to be taken care of all the time. And lastly, there's no room for recovery. And I think these misconceptions kind of perpetuate the wrong thing regarding some of these issues, and kind of makes it hard for the needle to move forward. So I think we, having these conversations really kind of helps to dismantle some of these beliefs that we have.
This is part of the reason I'm so excited to have this discussion, because especially coming from a population where this is stigmatized and continues to be and has generationally been, I just think these conversations are so important. How do we make these topics easier to discuss with family, with gatekeepers, with people who we trust? How do we make these topics easier?
I think psychoeducation is key, right? We have to, like I just said, dismantle some of these ideologies, preconceived notions, the things that were drilled into us from a young age by family members, by media, and kind of, you know, eradicate those narratives. And I think language is also important. You know, we've heard crazy used time and time again, right? That's not appropriate anymore. I think accountability is important. It's about checking the ways in which we ourselves perpetuate, you know, implicit and unconscious bias. It's how we normalize conversations around mental health. I am a big advocate of sharing my own personal experiences with mental health, right? And also being an advocate within my own, you know, faith-based community, and saying that, you know, prayer works as well as therapy. I'm an advocate for both, right? I would say practice authentic allyship. This means listening to others' experiences without judgment, increasing your understanding, developing and cultivating emotional intelligence and cultural competence. And lastly, just engage in healthy conversations like these, you know, educate your family, your friends, your colleagues, and literally everyone about the unique challenges that, you know, mental health, people with mental health, experience, and it is an intersectional and cultural issue as well. So I would say that.
I think I would also add that one of the hardest things to overcome for the folks who are actually in doing the work is this knowing that we are trying to pick up sort of pass the baton and pick up the baton from systems that did not historically want us there, right? Like on my first day of medical school, two of my non-white classmates, two white male classmates came up to me and they were like, what did you get on your MCAT? Like, how did you get here, essentially, right? And so I hope that one thing to take away from this conversation is that there are people who are doing the work, but we're facing some difficulties on multiple fronts, right? And so in this effort to have these kinds of dialogues, recognize that we're also we're integrating lots of environments, and we're in the process of balancing this work and trying to put it through our own, to make sure we're not the practitioners of diagnosing people with drapedomania, right? So please keep that in mind, that we're all trying to do this work. I think also something to keep in mind, like Ymani said, is doing the education like in the public. So there's also mental health first aid, which is a very popular training for folks who want to become more conversant and more aware around mental health conditions and how to be helpful to people in the community. So, I mean, I hope we can build a whole, just a whole legion of people worldwide who have done the work and built the vocabulary to keep on engaging their family and their community in understanding mental health conditions better.
All right, I would love to talk a little bit about how we as a community can continue to increase awareness and how we support people who are struggling with mental illness.
Karinn, go ahead.
Okay. So I think part of it, like I said, is engaging with the mental health first aid or the other, or Ymani, do you mind repeating the name of the workshops that you mentioned before?
Yeah, gatekeeper training or question, persuade, and refer training.
How do people find that? Because I'm sure people want to know, like, right now.
Yeah, there's a site. It's let me remember off the top of my head. I think it's just qprinstitute.com that you can go on to and get more information about that as well.
I think it's also useful to check out the psych.org, psych.org. Psych.org is the website for the American Psychiatric Association, and there's lots of information for the public on just how to have conversations around mental health. I know the American Psychological Association has a really good website as well. So I know that Google is free and there's lots of information. I think Ymani and I both want to help connect people to the kinds of information that's helpful and not the kind that's going to freak you out.
Yeah, definitely.
Absolutely. And yes, gatekeeper training is one of those things that I don't think will freak too many people out. I think it's a great kind of entry level into some of these issues, right? I'm going to say that I think everybody should be a gatekeeper, right? If we really want the world to be a better place. I also think being open, like I said before, about your own personal experiences will really create and increase awareness about these issues and break stigma and normalize it and encourage folks to seek help, right? I am a Black female Christian woman, and according to those standards, any one of them, I'm supposed to be strong, right? I'm not supposed to struggle with anxiety. I'm supposed to keep going. And that's just kind of the job that I have to do on top of my actual like life that I have to live, right? And I think we have to dismantle that because it's not healthy. And racial trauma takes a significant role on our mental, emotional, spiritual, physical well-being. And so to really have conversations around that. I think leveraging your social media. We are in a day and time where we may not have access to human interaction and connection like normal. And so using your platform, would be a great time or a great platform to speak out about these issues, ask questions, advocate for folks who are struggling with a mental illness. I would say keep attending events like this one, of course. Look out for holidays and events that promote awareness and destigmatization. Mental Health Awareness Month or Mental Wellness Month is in January. Self-Harm Awareness Month and World Bipolar Month is in March. And May is Mental Health Awareness Month, right? So I think being cognizant of when these events and initiatives are happening and staying with the times. And lastly, understand that mental health is a people issue and people are complex. People have identities and those identities intersect. And so you can't have conversations about mental health and wellness and care and disparity and not talk about those folks that are experiencing the lack thereof, of care and experiencing this disparity. So I would say definitely that.
I think there are also some books that can be really helpful. I know that there's books by Adrienne Marie Brown and even Charlemagne the God, the person from the morning show. He wrote a book about his own path toward understanding his childhood trauma better and how that affected who he has become. So look, we got reading from Charlemagne to Adrienne Marie Brown. You can read your bell hooks. We got Mindfulness for Depression by John Kabat-Zinn. There's so many really good tools out there. So the information is out there.
Definitely. And I know we touched on this a little bit before, but especially regarding the news about the Breonna Taylor case, I know, Ymani, you mentioned in your intro in your bio that you talk about racial battle fatigue. Could you give everyone who's on this, that's in this discussion, some tips to how to manage some of the feelings that we are coming to work with every single day in terms of this fatigue? I don't know if I had thought about it that way.
Absolutely. So firstly, just to define racial battle fatigue, it kind of has the definition in the word, but it's kind of this battle that people of color, more specifically Black people, have to encounter on a day-to-day basis to keep up the facade, right? To navigate conversations or not have conversations around issues like the Breonna Taylor issue, and, you know, experience and navigate emotional labor. And it's also talking about the detrimental and serious toll that microaggressions, you know, have on us on a day-to-day basis, right? And so I was just thinking this morning to, you know, experience what we've all experienced yesterday, and then to have to, you know, carry on our day-to-day lives, is a tall order, you know, and a tall task to ask people to do. And I think a lot of these manifestations, and I'm really passionate about talking about the manifestations of racial battle fatigue, because I know culturally we just go, go, go. And I think our check engine light is like screaming at us, and we're like, oh no, I'm good. And that's not, you know, okay, ideal, healthy. And we burn out very quickly, right? So if you are tired, if you sleep all the time, if you are overeating, undereating, if you are irritable, if you are sad, if you are crying, right? If you are angry, I think all of these signs, and I'm not even listing all of them. I mean, everyone has a different way of coping with grief and sadness and loss, right? But racial battle fatigue, I think, is a topic I'm really passionate about, because we don't talk about it enough, and it kind of dismantles and is the antithesis of some of the things that we've been taught through society and through familial values, you know? And so, I mean, I'm an advocate for self-care all day, every day. Take the time that you need. I had to before this started, right? And I think we really need to take that time out. So thanks for asking about that.
I think one thing I would add to Imani's extremely comprehensive response is that for lots of people, recognizing the symptoms of some of that fatigue and burnout is hard. So that's where Imani's mindfulness exercise comes in, doing that every morning if you can, doing that in the middle of the day if you can, doing that by the end of the day if you can, because there's really interesting research that shows that people who face discrimination and even vicarious trauma through seeing some of these fatal police interactions, people walk around with higher blood pressure when they are aware of all of those things. So, right, you could live in bliss and not turn on the news and pretend that you're in another place and that this is not the context for our time right now. But if your eyes are open and you talk to humans, somebody's going to mention Breonna Taylor, somebody's going to mention Ahmaud Arbery. So the hard part, and that's the part that I think keeps some of us doctors awake at night, is knowing that even just catching a whiff of this, and then say you go to the gym and somebody, does some sort of weird microaggression against you where they ask you, right, like, are you actually a member here? Let me see your identification, stuff like that, right? Your blood pressure might be higher than the average white person's, right? And it's the lived experience of being Black and brown in this country sometimes that does us in. It's not just that you were born Black, it's that you were Black here in this time, right? And so the other thing to keep in mind is that for lots of Black people, research has shown that even at night, when everybody else's blood pressure is supposed to go down, you're unconscious, you're asleep, you're dreaming or whatever, there's a subset of Black people whose blood pressure does not go down, right? And so, and it's a significant enough number that people are having to go on blood pressure medications, or they're having to adopt a mindfulness practice and work extra hard at controlling the stress that they're exposed to, because it has the potential not only to affect your mind the way that Ymani talked about, but it has the potential to affect your body.
Wow. Thank you. We have a few questions from our participants, and I will ask just a couple of them because I know we're almost running out of time. We had someone ask, are there disparities in treatment for men and women?
Meaning rates of engagement? Like, do women show up for treatment versus men? Typically, this is off the top of my head. I don't know for sure, but in my experience, women are more likely to come for treatment. Yeah. And it also depends on the diagnosis, right? Schizophrenia is one thing. Bipolar disorder is another thing where I think the rates are quite similar. But when it comes to depression and anxiety, I think there are probably some differences. Yeah.
And just to touch on the stigma too, I think things like self-care and mental wellness are more hashtagable for women, versus that of men, right? And we talked a lot about stigma before. I definitely think there are some disparities between the two. And that's something to note as well, just to add a little.
Definitely. So Lois asked, to what extent is unconscious bias a result of a hardwired brain that sees someone that looks for themselves automatically as a them? And what can we do about it?
I love that question. So I think there's a website that helps you understand what some of your biases are. I want to say it's tolerance.org. But if you look up, if you Google unconscious bias test, there are a couple online resources where you can gauge where your biases are. And then I think it's a matter of looking at like what we call identity work. So I have come to understand that as a Black, cisgendered, heterosexual woman, I have had a certain experience in my life. I've been through lots of education, right? So I move through certain circles and I have to constantly check myself. And sometimes I rely on my patients to just go like, this feels funny. For example, I had a patient, so I work in the Bronx where in neighborhoods that are policed very differently from other neighborhoods where I grew up and other neighborhoods where I've lived. My Black and Latinx patients were coming late to their appointments for like a while. I kept on noticing it was like a year. And I was like, what is going on? Why is everybody so late? And they keep on saying they were stopped by the police. And I was like, maybe they're just not telling me that they're like secretly doing drugs or like dealing drugs somewhere. Also some of my patients do have a record of some of those behaviors. So I was like, maybe they just don't want to tell me. But then it dawned on me when in the news, stop and frisk was so routinely and negatively impacting the lives of my male patients particularly, right? As a Black woman, I was not encountering that. But as Black and brown men, they had a completely different reality. So I had to check my own biases and check my own assumptions. So those are some of the things, like you really do just have to keep on listening, checking media sources that are not necessarily the ones that end up on your feed. You sometimes have to look at the footnotes, and those are some of my recommendations.
I like that, everything that you just said. And I think now would be a great time to just say that not everyone's experience is the same. Not all people of color's experiences are the same, right? And so keeping that in mind will help kind of shift your thinking a little bit, I hope. Anyway, I just posted something on LinkedIn and it was a video of, I think like 3 Black men in a restaurant seemingly arguing, and they were like pushing each other, shoving each other, seemingly yelling at each other. And on the outside, there's a white couple that's like, oh, they must be in a gang, blah, 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 blah. That was kind of the narrative that has been perpetuated. And so that's what they ran with, right? But then a few seconds later, you see the gentleman hugging and laughing, right? And then when you kind of go into the restaurant, you discover that they are acting out a Shakespeare play. And so I think, and that kind of just changes the whole narrative, right? As to some of the things that we think. And even just keeping in mind some of the small things, right? I think Black male faces are the most feared faces, no matter if they're smiling, no matter if they're frowning, right? Just some of the things that we constantly don't even know that we think about, and kind of dismantling some of these unconscious biases and false truths and narratives that we hear on a day-to-day basis is really important. And I think another test is Harvard has another implicit bias test as well. So I would say that too.
Thank you. We have a question from Anonymous. How do individuals assist people of color in both African American and Latinx communities with additional economic help to make mental health care more affordable?
So I'll offer that there are lots of organizations to donate to that provide mental health assistance, particularly for people who are coming out of being incarcerated. So the Fortune Society is one of them. I mean, I'm just talking about ones in New York. The Osborne Association is another one. You can always donate to NAMI, the National Alliance for Mental Illness, or Mental Health America. I think a lot of these organizations also, if they're not doing the work directly, they also give grants to other community-based organizations. So I think it might be a small thing to just like do a Google search about which community-based organizations in your area are focused on mental health and donating.
That's awesome. Sterling asked, thank you so much for all of this information. As a Black lesbian woman, how do I disclose to colleagues about the need for mental health space within the workplace?
So I'll offer my little bit, and Ymani, you chime in because I know you do some of this work as well. So I am on the Workplace Mental Health Advisory Council for the American Psychiatric Association. I've been doing some work with them around how to make it easier for companies to provide spaces. So part of it, I think, is going through HR, because the HR benefits managers are the people who are like their day and night, 24 hours a day, supposed to be thinking about how to keep their talent in-house, how to keep their employees happy and safe. So the HR benefits folks are really putting, especially in the light of racial trauma and COVID, trying to create spaces for folks to talk about some of these really tough issues. And then I think also it's important to gauge whether the workplace is having open discussions about that and whether to start some sort of group, but then also to think about the nature of privacy at work and how much you want to disclose and whether that could factor, like not every work climate is ready for those conversations. So Ymani, what do you think?
Oh, you're on mute, Ymani.
Thank you. I definitely agree. I think to your point about kind of testing the waters to see, where organization is at in terms of these issues is really important. I'm definitely an advocate for healing circles. And I think the second point I was going to say is kind of decolonizing some of the otherness that we feel, right? Ask yourself the same question. If a white cisgender male were to say the same exact thing, what would the reaction be? Right. And so, right. So, think about that answer, and that should be, your approach going forward. And if it would be provided for them, help for them, assistance for them, support for them, understanding for them, then that's something that you too should also receive. And so I think thinking about how you can have some of these conversations that take boldness, emotional labor, unfortunately, and maybe you may have the strength and encouragement and boldness to really step forward and initiate some of these things like healing circles, like implicit bias training before you even, and you may want to start there, right? Just to kind of test the waters to see where, everyone is at before you start going into these broader issues that may be, unfortunately, a larger pill for them to swallow. But those are my thoughts regarding that.
Thank you. Chia asked, how can progress be made or what are some ideas for progress for the education system and community mental health services to identify and treat trauma more effectively?
So I'll start by talking a little bit about the model at Montefiore, which is the hospital system where I work. It's a health system that serves the Bronx and Lower Westchester and on into the Hudson Valley in New York. So at our primary care centers, whenever people come in, or before COVID, whenever they would come in, and now when they check in over through the apps to check in for their visits, people would get asked 5 questions. 2 questions about depression, another 2 questions about anxiety, and another question about problem drinking. And the idea was that by answering 5 simple questions, whether you're coming for a vaccine, whether you're coming to get your blood sugar checked, or your hypertension addressed, or your blood thinner, or whatever, you're going to be asked about whether you're feeling hopeless, whether you're enjoying life, whether anxiety is keeping you awake at night. And so by the time you see your primary care doctor, that person has a sense of like how you're doing emotionally, how you're doing with your mental health. And that person then should be asking you some follow-up questions. And so this is the beautiful part, is based on your answers to those questions, they can say, hey, it looks like you're having kind of a hard time. We got this lady down the hall. Would you want to meet with her? Because she's skilled at therapy. Or at least, you know, we don't have to call it therapy because I know that freaks some people out. But she's skilled and she knows what she's doing, and she's from the neighborhood. Why don't you just meet with her? She can ask you some more questions better than I can. And let's see, because after all what she does is she helps people feel better within 4 or 5, sometimes even 2 visits. Sometimes it only takes 1 visit to just feel better. So what do you think? Just, you want to meet with her? And so that person who's a social worker in the case at Montefiore, will meet with the patient, if the patient's willing, every 2 weeks. They'll do what we call a PHQ-9 or a GAD-7 to assess depression and anxiety symptoms. And then based on that, if there's progress, this person will keep meeting with this person, and then they'll finish, right? Having felt better. If it's not working out that well, or the person is not getting better, that social worker, trained therapist, will talk with the patient and talk with the primary care doctor or the GP and say, hey, this person's not getting better. Would you mind talking to them about medication? And then that's how the conversation advances, always with the idea of like, we want to get you better and back to functioning.
Right. And I want to touch on that too. Can you qualify the age group that the question was centered around, just so I can answer the question correctly?
Let me see. It wasn't specifically called out.
Okay. So I think I remember hearing school setting in some way.
Well,
okay.
The education system.
Okay. So I think it's really important that people are knowledgeable and aware of, even if they don't practice them, you know, evidence-based practices. There's trauma-focused cognitive behavioral therapy, you know, child play therapy, narrative therapy. And I think even just understanding the basic fundamentals of some of these things will kind of give you a foundation on how to navigate conversations around trauma in the school system. That's just my little note. I think that's just really important to understand. And also practicing empathy. And it sounds really small, but I think everyone could use a little bit more of it. And I think when you're talking about a school setting, you don't understand or know fully, you know, what they're experiencing at home. And we already talked about some of the stigma that may be perpetuated for children, especially children of color. And so I think keeping that in mind is important as well too.
Definitely. I'll add that Montefiore does that with kids as well. There's a whole pediatric behavioral health intervention program and integration program. So it's called BHIP. And it's at all of our sites in one form or another. And so essentially it comes down to screening widely, meaning asking people like, hey, you're here for your blood pressure, but we got these 5 questions. And it's by doing that we normalize that, like, your mental health is part of your physical health, and we care about you as a whole person. Because I recognize not everybody wants to go to a psychiatric clinic for help, and for some people it's really hard to find a therapist. And so if you happen to find one who's in the medical doctor's office near you, and all you have to do is just walk down the hall to see that lady or walk down the hall to see that guy, then, like, yeah, let's remove all the barriers.
Definitely. Well, we had such a great discussion here today. I want to thank you both for joining us. This was so informative, so insightful, and we really appreciate you sharing your knowledge with us. Also want to thank my meetup team for the support. And I'm going to quickly share some resources that we wanted to highlight for those who were interested. And I will leave this up here. We want to thank all of our participants, all of our guests for joining us in this discussion today. This recording will be available up on the Meetup blog for viewing, and I hope everyone has a great night. Thank you so much.
Thank you.